Good evening, everyone. I welcome you on behalf of Sanofi and Associations of Physicians of India for today's webinar. The topic for today's discussion would be revisiting the innovations in management of allergic rhinitis. And to take the proceedings further, we have a moderator for the day, Dr. Sowmya Nagarajan. She is a consultant pediatrician, an allergist, and immunologist from Sanjeevani Hospital, Sanjeevani Specialist Clinic, Bengaluru. We have with us a couple of speakers, which Dr. Sowmya Nagarajan will introduce. And to take the proceedings further, I welcome Dr. Sowmya. Over to you, ma'am.
Good evening. Thank you, Dr. Ketan, for the kind introduction. It's indeed a privilege to be moderating this exciting session on allergic rhinitis and the recent innovations in the management of allergic rhinitis. So, firstly, we would have Dr. Agam Vora, for the speaker for the session today, subsequently followed by a panel discussion. So Dr. Agam Vora doesn't need any introduction. He's an eminent pulmonologist from Mumbai. Sir has a very series of credits to his name, but in short, he has been the ex-assistant honorary professor in the Department of Chest and Tuberculosis, Dr. R.N. Cooper Muni General Hospital, Mumbai. He has been in the capacity of ex-assistant professor, Department of Chest and Tuberculosis, KJ Sowmya Medical College, Mumbai. He has been the assistant editor for the Journal of Association of Physicians of India, which I have also contributed a couple of articles. General Secretary of the Association of Physicians of India. Sir has also been the General Secretary of the Academy of Advanced Medical Education. He's been the past president of the Pediatric Society of India, among many of his acclaims or accolades. Sir, before I pass on the bastion to you, I just want to share a few slides about introduction of allergic rhinitis with your permission. So usually allergies are very common, and very common situation we see in our day-to-day practice, pediatrics or adolescent geriatrics alike. Many a time patient comes with history of blocked itchy nose, almost sneezing every day. It affects the sleep and daily activities, very commonly being treated with nasal drops, over-the-counter oral decongestants with minimal effect. But doctors say his symptoms may be contributed with allergy, but parents, again, because they stay close to the main road, they feel it may be proximity to the dust. In a way, both thought processes are right, but very different from each other. So how do we proceed? Mainly, the prevalence of allergic diseases have been increasing worldwide. Sorry, one second. That was 1 second. Is it visible now? Is my slides visible now?
Ma'am, do you want me to share the screen?
1 second. Is it visible now?
Yeah, it's visible now.
Okay. So prevalence, sorry about that. The prevalence of allergic diseases have been increasing worldwide with associated industrialization and urbanization. So globally, about 400 million people are known to suffer from allergic rhinitis. And according to the WHO report, every year about 3 million people die prematurely due to outdoor air pollution. So many factors contribute to the increasing evidence of atopic from childhood among particulate matters, increased use of antibiotics, increased climate change, decreased biodiversity, increasing use of detergents, chemicals, among others. So allergic rhinitis is mainly an IgE-mediated disorder, which is triggered by exposure of nasal mucosa to allergens. Classically, sir will take us, but very briefly, it is seen by paroxysmal sneezes, rhinorrhea, nasal itch is the main factor, nasal blockage with or without is associated with itchy of the nose, palate, ears, or the eyes, which responds very classically to antihistamines. So allergic rhinitis is not a disease of the nose alone, because it is being given more importance because of the associated comorbidities, which can have a very drastic impact on the life of these patients, because it may be associated with other atopic diseases like asthma, atopic dermatitis, conjunctivitis, nasal polyposis, but also decreased quality of life, leading to school absenteeism or work absenteeism, and definitely having an effect on the quality of life. So ARIA classification is mainly allergic rhinitis and its impact on asthma classification. Mainly we classify based on the number of days being involved or the number of weeks into intermittent or persistent, if it is less than 4 days a week or less than 4 weeks. If it is beyond that timeline, it is persistent. If there is no impact on the day-to-day activity of the symptoms, it is milder. And if it is affected, even in one or more of the sleep activities or the day-to-day activities, it falls into the moderate to severe categories. I would hand over the dais to Dr. Agam Vora sir to take the talk forward.
Good evening, everybody, and thank you, Dr. Sowmya, for that fantastic presentation. You have really set the context properly. And I'm so comfortable with these two learned faculties with me, Dr. Sowmya there and Dr. Vineet there. So I'm sure whenever I'm stuck, I have two helping hands with me. I must thank Team Sanofi for giving me this opportunity to be here in front of you. And special thanks to Dr. Ketan. My association with Ketan is 5-6 years old, and we have done a lot of scientific programs together. Priya, and a lot of people who have worked hard to make this happen, to connect me to those hundreds and thousands of you. I must mention thanks to Anirudh, 1MD, the technical guy who's given me this platform to connect. And my next half an hour's discussion is going to be the management of allergic rhinitis. I must express my sincere thanks to my teacher as well, Professor Director Dr. K.C. Mohanty, late Professor Dr. K.C. Mohanty, and of course, all of you who chose to be here today evening, talks about your commitment to this subject. I asked Sanofi, I asked Ketan, why do we do this program on this working day, 22nd April evening, 7:30 baje, it is OPD time. And he said, no, the program has to happen today. It is very important day. 22nd April happens to be a National Earth Day, where there would be campaigns all around the globe to promote ways to keep Earth healthy. 22nd April also happens to be a national Teach Your Children to Save a day. Oof, the most difficult thing. How do you handle your kids, and how do you handle your kids and tell them to handle money? Oof, something that I've never successfully done. Today happens to be a National Jelly Bean Day, happens to be a National Stationery Week. That is, today is included in 20th to 25th April, which is considered as National Stationery Week. I didn't know that. When I Googled, I realized. It is a day to sharpen your pencils and break out from your fine pens. Take this excuse to use some fancy stationeries. You can write a letter to loved one, you can find a pen pal, you can even make to-do list. And if you like this presentation, you can even send a written message to me. So that's how important today's day is, and that's why the day is chosen for this CME program. Okay. COVID. Last few days, we are seeing again a surge in COVID. I was getting a sign of relief at the back of my mind. I thought pandemic is about to get over and life is getting back to normal. Conferences have started and I would be able to meet you all personally. But COVID again made us go virtual, and that's where I am talking to you virtually. About 50 crore cases globally, 62 lakhs direct attributable cause to COVID, 4.3 crore Indians we feel had COVID, and 5 lakhs direct deaths due to COVID. We've lost official figure of about 2,100 doctors because of COVID. Last couple of months, though we saw a slight surge in COVID cases, luckily mortality is not high, and we have kind of understood disease well. We've kind of had our hands on this newer antiviral drugs. The vaccines seem to work well, and we believe that probably there may not be a bigger problem like what we had with Delta wave or Alpha wave earlier. It would be a milder version, and COVID seems to be under control. But what we could not control over many years is the rising violence against doctor, and this loss of this innocent life is really painful. She's the victim of brutal killing by police, politicians, media, society by and large, and you and me are also responsible to some extent. And she lost her life while serving humanity. Let this story be not over, and we must continue our efforts until justice is served. Anyway, coming back to the topic for discussion today, and that is going to be allergic rhinitis. As Dr. Sowmya said, the way I understand allergic rhinitis, it is a symptomatic disorder of nose, which is induced after allergen exposure, which is Ig-mediated inflammation of nasal membrane. So you know this nasal mucosa can be affected by various mechanisms. When it is IgE mediated, I'm sure you recall your pathophysiology days. With the exposure of allergen, there are IgE antibodies which are created. On the subsequent exposures, this IgE antibody gets bound to this mast cell. And these two short arms, when they are exposed to this allergen again, the circuit gets over. And then it brings about degranulation of mast cells. So mast cells degranulate and releases histamine immediately. And then there is a second wave where there is a slow releasing inflammation which progresses. You have leukotrienes which are released, and then that brings about a second stage of inflammation, and that is the pathophysiology of allergy-mediated or IgE-mediated allergy-exposed inflammation. This inflammation leads to rhinorrhea, nasal congestion, nasal itching, and sneezing. So these are the 4 features which a patient presents you with. That means they have running of nose, sneezing, itching, and obstruction. Something is stuck there. This was very beautifully spoken about by Sowmya. It talks about the way we are now classifying allergic rhinitis. So we are looking at whether it is intermittent or it is persistent. We are looking at whether it is mild or moderate to severe. So you have based on the frequency of symptom, which may be less number of days for lesser weeks. Anything less than 1 week and few number of days per week, it is intermittent. But whenever it is more number of days, say more than 4 days for more than a month, you call it as persistent. And depending on severity, it may be mild or it may be moderate to severe. Mild, where your activities are not lost. You can continue working. Though your problems, your sleep is not disturbed. Whereas moderate to severe, your sleep is disturbed, you find it difficult to work, and these symptoms are really troublesome. So you have a combination of, you could have mild intermittent or moderate to severe intermittent, or you can have persistent, which is mild or moderate to severe persistent. So these are the different phenotypes that you would come across in your clinical practice. And trust me, this is not only the problem of your and my area. It is not only the problem of a country. This is a problem across the globe, and we believe significant number of people suffer from allergic rhinitis. Our population has prevalence of about 10 to 30% is what is prevalence of allergic rhinitis in adults, and about 40% it is children. It often begins at very early phase in life, at about 6 to 7 years, and probably continues even in adult life. 20 to 30% is suffering from allergic rhinitis is what is thought about. It has got various presentations. So it has got various comorbidities. So you have allergic rhinitis associated with chronic rhinosinusitis with polyps there, otitis media with diffusion there. It may be associated with obstructive sleep apnea, it may have association with adenoid hypertrophy, and the patient's presentations and disease behavior is different. The sufferings are different. Talking about allergic rhinitis, its effect on sleep, it can impair your quality of life. So apart from its effects on nose, it can affect your quality of life. It can have, people may have more difficulty in falling asleep and then suffer from nocturnal awakening. Not only that, a significant proportion of this patient will have associated asthma. And I believe allergic rhinitis and asthma are probably part of the same disease spectrum. So on one hand, you have a predominant allergy rhinitis presentation, on the other hand, you have predominant asthma presentation. But when you take detailed history, when you evaluate this patient, when you do their investigation, you realize most of these patients have coexisting other diseases. They may not be aware of this, or they may not be bothered about it. So you may have a milder allergic rhinitis and more severe asthma, and hence their whole focus is on asthma. And most of the treatment that you offer may take care of associated comorbidities. In the sense, if you treat your asthma with leukotriene receptor antagonists and antihistaminics, your allergic rhinitis will be taken care to some extent. When you treat your allergic rhinitis very aggressively with this treatment, your asthma milder form can be taken care of. And these are the current pharmacological modalities. So you have the most common thing is allergen avoidance, and which is missed most of the times. We tend to forget taking this history. We tend to not give adequate advice about this to our patients, and we forget to tell them to look after their pets, those birds in the house, those paints, those funguses there on the walls, etc. But when it comes to pharmacotherapy, oral antihistaminics are the drug of choice, which most of these family physicians, most of these allergy practitioners use. Though the most preferred treatment as per the literature and as per those allergy specialists, as per ENT specialists, as per most of the guidelines and a chest preferences, intranasal corticosteroids. So the first line of treatment for allergic rhinitis, if you ask me, for be it intermittent or be it persistent, when it is moderate to severe allergic rhinitis, my first choice would be intranasal corticosteroid. If my intranasal corticosteroid does not give adequate relief to my patient, then my add-on will be antihistaminic, which I may give through the nasal route or which I may use orally. And then comes leukotriene receptor antagonist, and yes, there is evolving role of allergen immunotherapy. Somehow it's not very popular amongst chest physicians, but ENT colleagues used to, are more, how do I say, they prefer this allergen immunotherapy more than other specialties. When you look at what treatment offers the best relief when it comes to sneezing, itching, congestion, and rhinorrhea, trust me, your leukotriene receptor antagonist, your Montelukast, would be good for the congestion, but it has got very poor effect when it comes to sneezing, itching, and rhinorrhea. Oral histaminics are very good taking care of your running of nose, the sneezing and itching part of it, but they don't take care of congestion very well. But when it comes to intranasal corticosteroid, you can see that in the third row, it looks after your sneezing, itching, congestion, rhinorrhea equally. Even intranasal antihistaminics have got very good effect on sneezing, itching, congestion, and rhinorrhea. So all four complaints, all four symptoms that you could have with allergic rhinitis are taken care of with intranasal corticosteroids and intranasal antihistaminics. You may ask me, what's your preference of intranasal corticosteroid versus oral antihistaminics? Trust me, steroid reduced your total nasal symptom score by 25% more than placebo, and oral antihistaminic decreased it only by 5%. So when you ask me the choice, my choice for intranasal corticosteroid would be first, and that has got strength of recommendation level B. Look at the second point there. Intranasal steroid improves subjective eye symptom score as well or better than oral antihistaminics. In the sense, you may wonder, even the ocular symptoms are taken care of with your intranasal corticosteroids. Of course, not all steroids do that. There is a preference of certain steroids over it, but then it has got fairly decent strength of recommendation, that is level A. You may ask me, if that is the literature, what are the limitations of current treatment modality? Current treatment modalities, your choice of molecules may not be right. In the sense, you may have chosen steroids which do not have adequate control of ocular symptoms. You may have sleep disorder, which decreases your productivity at work. You may have more of rhinitis. You may have more of blockages. You may not have put your enough attention on. There may be inadequate control with the therapy that you've chosen. In the sense, you may require a combination therapy now. And if you're giving a too complicated regimes, multiple devices and multiple treatment options, maybe some syrups, maybe some tablets, maybe some injections, maybe some nasal drops and nasal sprays, probably that would complicate the issue and would reduce the compliance. And then there is a role for giving them a single device, a very simple treatment plan, which would be most, where patients would be most compliant. Like you give 2 different devices at 2 different time structures, you give one in the morning, one in the evening, etc., may lead to a lot of confusion. Changing the intranasal corticosteroid molecule or increasing its concentration or increasing the dose have not been shown to give you adequate symptom control. Addition of oral therapies, that is oral antihistaminics or leukotrienes, etc., offer minimal benefit over intranasal corticosteroids. But when you get chance to give intranasal, antihistaminics versus and the nasal corticosteroids in 2 different devices, probably they require more time, they require more training, they may require, the timing, the distributions, etc., may get things complicated. And then what you need to do is you need to probably give them very simple treatment, probably in 1 device, probably a simple treatment chart like once or twice a day. The gaps at a pathophysiological level will be oral antihistaminics and leukotriene receptors. They act at a single site on single pathway. As I told you, the histamine will be released, antihistaminics acts there. The leukotriene receptors would be blocked by the leukotrienes which are released, which takes some time, but it acts on the same path. It takes some time. Your antihistaminics may work faster, but then montelukast or your leukotriene receptor antagonist will take some time. And they may have limited benefit when it comes to congestion. So some of the congestion is not taken care of very well. Intranasal corticosteroids would take another, there is a time gap. It does not act fast. It takes, in fact, few days before its optimal action. And all intranasal corticosteroid may not give you benefit when it comes to ocular symptom management. So no single medication class is capable of providing rapid and full relief in moderate to severe cases. I'm not talking about mild cases. I'm not talking about intermittent cases. Imagine a patient who's got persistent symptoms. Imagine a patient who's got moderate to severe symptoms. There you may not be doing enough good by providing what you are, and you may need to revise your decisions. What combinations guidelines recommend? The guidelines recommend that combination of intranasal antihistaminic and intranasal corticosteroid in the condition where it is not controlled with monotherapy alone. So you have a situation where you have given them intranasal antihistaminics, you've given them intranasal corticosteroid, but they're not doing well. They are still symptomatic. Probably that is the time to give them a combination therapy. And this moderate to severe perennial allergic rhinitis, it works well, and you have got fairly decent degree of recommendation. But when it comes to non-allergic, you don't have enough evidence for that. This particular modality of treatment, by and large, would give you relief when it is allergic, maybe seasonal or perennial rhinitis of moderate to severe variety. 2016 guideline also spoke about the same thing, the area guidelines, which talks about intranasal antihistaminic and intranasal corticosteroid for the initial treatment of moderate to severe seasonal allergic rhinitis in patients who are 12 years and old, because there is definite benefit over monotherapy, which is quite understandable. And combination in a single device offers better coverage, faster symptom control, and better compliance. Let's look at the experience of combination therapy with intranasal corticosteroids and intranasal antihistaminics. So it would be like bridging the gap. Whatever there is lacuna in the therapy, these two, when given together, would take care of most of these presentations. So antihistaminics would work fairly faster compared to your intranasal corticosteroid, which would take about a couple of hours to a couple of days, where antihistaminics intranasal would work in minutes. It is an immediate short-term relief which lasts up to 12 hours. And there may be fast-acting drugs which takes care of that early phase. You know that there are 2 phases. First phase is histamine release and second phase is leukotriene release. So the second phase is taken care of by long-acting intranasal corticosteroid. It gives you a sustained symptomatic relief, and hence both these aspects, the first phase and the second phase, are taken very well care of with this combination. The direct mucosal application towards receptor site at the source of inflammation is the rationale for combining these two. You can imagine there is an inflammation there, and when you give spray which acts locally, The additive effect from different mechanism, both have a different mechanism of action, hence there will be a synergistic action or the additive action. Combination of fast-acting intranasal antihistaminic with long-acting intranasal steroids are more effective than monotherapies. You give combination therapy, that obviously is going to work better than both therapies given individually. Intranasal antihistaminics are effective in rapidly reducing nasal symptoms like itching, rhinorrhea, sneezing, and even your ocular itch. In the sense, the irritation in the eye will be taken care of by intranasal corticosteroids and intranasal antihistaminic combination. Steroids may be effective in reducing nasal congestion. When you give this, there is hardly any, I mean, we have experience of using it for like number of years now and seen hardly any side effects and minimal risk of systemic adverse effect because they are hardly absorbed in system. You would ask me which is the antihistaminic of your choice, and my choice currently, as of now, with the understanding I have, is on azelastine, and I'm going to show those slides to you. Why azelastine? Fast-acting, effective, well-tolerated H1 antagonist. It's a newer generation antihistaminic, and antihistaminics are available in various forms, and this form is available for local application as well. So it has a mast cell stabilizing effect, anti-inflammatory effect, and with this, it reduces the concentration of leukotrienes and the other inflammatory mediators like your platelet aggregating factors and various kinines, etc. It has a fairly superior efficacy, fairly rapid onset of action. It improves your nasal symptoms with rhinitis, such as nasal congestion, and even the post-nasal drip. It is effective even in patient who did not respond to other antihistaminics. So say you have given somebody another drug in the same group, that is your H1 antagonist, the second generation. The patient has not done well, and when you give them intranasal, you may find them working well now. Effective at lower dosages as well. So you give one spray, that also is effective, but when you give 2 spray twice daily, probably it is more effective. And luckily, very well tolerated both in adults and children. That is a fast, long-acting effect based on its mast cell stabilizing property, its anti-inflammatory property, and anti-allergic property. It also lowers the neutrophil and eosinophil counts and decreases intracellular radiation of ICAM expression on nasal epithelial surfaces. So it has got multiple action. It inhibits the mast cell degranulation, and hence all inflammatory mediators are not produced. Whatever inflammatory mediators are, it will bring about the suppression and will bring about anti-inflammatory action there, and its effect on leukotrienes would make them anti-allergic as well. When you look at number of studies which are there, which compares this nasal spray with various antihistaminics which are available for local use and which are popular in practice, like your cetirizine, your loratadine, your ebastine, your terfenadine, or oral cetirizines, etc. When you look at all this, you find the study or these graph favors the use of azelastine nasal spray. So when you look at the global assessment and efficacy as the outcome, when you compare it with other oral agents, you say that most of the study favor the treatment with intranasal azelastine. It also talks about its effect in seasonal allergic rhinitis, where effects are seen in as low as 15 minutes. When it is compared with desloratadine on first graph and compared with cetirizine on the other graph in both seasonal allergic rhinitis, you can see that mean daily improvement from baseline to day 14 in combined morning and evening 12-hour reflective total nasal symptom score favors the use of azelastine nasal spray. Fine, you may ask me now, which is the steroid of your choice? And my choice steroid would be again fluticasone furoate. Fluticasone furoate, why? New topical corticosteroid with enhanced affinity, high potency, low systemic bioavailability, onset of system and relief about 8 hours in initiation of treatment, gives you fairly decent 24 hours control, comprehensive coverage of both ocular and nasal symptoms. This is unique property of fluticasone furoate. You may have used other steroids, and this other steroid may not give you benefit when it comes to ocular symptoms. Imagine you give a spray in the nose and it takes care of ocular symptoms. Fairly safe, well tolerated, and trust me, the delivery device also makes a very important difference. You will see a lot of devices in market, but if the device does not deliver the drug well, A very good drug may also be useless. I could lay my hands on various studies which came right from 2000, 2005, 6, 7, 9 to recent studies, and I was looking at its effect in seasonal allergic rhinitis and its effect in perennial allergic rhinitis, and I found that most of this study talk about the favorable outcomes with fluticasone furoate and makes me confident about its use. The glucocorticoid receptor affinity of this steroid is far better when it compared with other molecules of the same class. So you look at the glucocorticoid receptor affinity, which is there in black. You can see that when you compare with mometasone, fluticasone, propionate, cyclosonide, budesonide, and dexamethasone, you can see that this has got the greatest relative receptor affinity. You may have come across the other molecule of the same class, and that is fluticasone, same molecule with different salt. So you have fluticasone furoate and a fluticasone propionate, and there are sheer advantages of fluticasone furoate as it has enhanced affinity of the target receptor. So when you give a lower dose, the same drug at a lower dose will be as efficacious. So you have fluticasone furoate, which is given at 110 milligram, whereas when you give fluticasone propionate, you may have used 200 milligram. It gives you superior symptom reduction at the lesser frequent dosages. So you may have to give twice a day dosages when it comes to propionate. Furoate, you may get away with single dose. It has got higher affinity for both nasal and lung tissue. And of course, you have to use less, and probably there may be health care cost advantages as well. There are multiple studies available. I could lay my hand on this study, which talks about multicenter randomized placebo-controlled double-blind parallel group study looking at fluticasone furoate versus fluticasone propionate, and it talks about the treatment with once daily was effective and non-inferior when it was compared with twice daily propionate. So you are giving once daily fluticasone furoate versus twice daily fluticasone propionate, and at lesser dose, it brings about same effect, and it has got hardly any side effect. When you ask patients which product they like, when you give them two different inhalers, try to two nasal sprays and look at their attributes, and they said the odor or the smell was far better with the furoate. Aftertaste was far lesser with furoate. Leaking out of nose and going the drug down the throat was far lesser with furoate, and the mist gentleness, the overall experience was far superior when it comes to furoate versus propionate. And then there are sheer advantages of putting this in one device. So see, if you have to give this drug in two different devices, I'm sure you would agree that the treatment gets complicated. Patient has to remember which one he took it first, and it's not only disease of young patients, it is disease of senior people as well. Even your elderly population will be at risk of getting allergic rhinitis, and you can imagine the complexity of treatment. There may be so many treatment patients may be on, and then to remember different devices. When you give them in a single device, it gives you not only better coverage, which is greater than monotherapy, it gives you quicker symptom control. It will help you in a better distribution of drug. There would be improved adherence. So your compliance would definitely be better when you give them in a single device. Okay, we understood about allergic rhinitis. What about the comorbidities I flashed right in the beginning? I spoke about so many comorbidities your allergic rhinitis patient is going to get. It's not going to be a garden variety cases that we are taught in our undergraduate or postgraduate days. When we see in practice, you see most of these patients having so many comorbidities. So you may ask me, would it be useful in situation where I have allergic rhinitis with chronic rhinosinusitis, where I have allergic rhinitis with nasal polyps, when I have allergic rhinitis with obstructive sleep apnea, or maybe adenotonsillar hypertrophy? And answer is yes. You will come across various studies which talk about its association with chronic sinusitis. So you have allergic rhinitis with chronic sinusitis. Look at the level of evidence. A, the box that I've put in red in front of you, intranasal corticosteroid spray improve the symptoms in patient with chronic rhinosinusitis. And that's the A level evidence. And hence it can be a drug of choice when you're thinking about treating allergic rhinitis with rhinosinusitis. Look at this, another study which talks about its use in acute rhinosinusitis and talks about, yes, fluticasone furoate would reduce the symptoms of uncomplicated allergic rhinitis with sinusitis compared with placebo, which is well tolerated and provides support for withholding antibiotics in selected subjects. And that could be a game changer study where unnecessary use of antibiotics can be avoided. Look at in patients with polyps. Yes, topical steroids are more effective on certain nasal polyp phenotypes. And though it may be essential to understand its phenotype, but yes, intranasal corticosteroids would have great advantage in these situations as well. Sleep apnea, intranasal corticosteroid was effective for OSA in decreasing apnea-hypopnea index. It is effective in subjective sleep-related quality of life outcomes, and it would reduce the inflammatory markers and adenoid levels, etc. The interleukin-6 secretion from adenoid tissues in children with obstructive sleep apnea syndrome. And it was proved that yes, fluticasone furoate may reduce the inflammation in children with OSA syndrome, mainly the reduction of interleukin-6. I would come at the end of my presentation by giving you some key highlights, and that is intranasal corticosteroids are recommended as first-line therapy for effective management of moderate to severe allergic rhinitis. Patients who do not do well with this monotherapy, a combination of intranasal antihistaminic must be considered. When you ask me my choice, I think the enough data which talks about combination of fluticasone furoate and azelastine, the combination has helped me in most of the tough situations. There is improved adherence when you give it in single device. One spray application would give you uniform distribution, and it is fairly decent retained in your nasal cavity. And patients benefit from additive effects that result from different mechanisms and hence have a synergistic action. And fluticasone furoate reduces symptoms of uncomplicated acute rhinosinusitis. It reduces symptoms of uncomplicated acute rhinosinusitis. It reduces interleukin-6 levels in patients with associated obstructive sleep apnea. I would end by saying that how something appears is always a matter of perspective. You can see a cylindrical object which is kept in the center, and somebody may see it as a circular object, somebody may find it a square there. Everything we hear is an opinion, not a fact. Everything we see is a perspective and not the truth. And I leave this to your wisdom to interpret the studies the way, and probably I would be very happy to share your experience to take up any questions that you have. Thank you very much. Over to you.
Thank you, sir. Thank you for an elaborate and a new perspective on the recent recommendations about possible treatment options in treatment of allergic rhinitis. And before we proceed further, I would want to introduce and welcome Dr. Vineet Sehgal to our forum. I think in pediatric circles, Dr. Vineet Sehgal is a very known name. He is presently consulting, in his own private practice for the past 24 years, and he's a pediatric pulmonologist affiliated with Max Healthcare Hospital in Delhi. Sir has been a master trainer and faculty for various asthma training modules under the aegis of Indian Academy of Pediatrics. He's also the group education module and the secretary of IAP respiratory chapter at the national level, and for various years under the Delhi State Respiratory Chapter. He has various publications to his name, and his core interests lie in pediatric pulmonology, respirology, and vaccinology. So, welcome to the forum. So, Agam sir, so I think we have a mixed panel today, so we can hear both the perspectives of pediatric as well as the adults practice in allergic rhinitis. So we have few questions, if I can take it up. So you did mention, sir, the role of probable the choice remains intranasal steroids as the first line in the management of allergic rhinitis. How would you define what would be the ideal approach? What times you think monotherapy should be given, and when the combination therapy. You did briefly touch upon, but probably you could give a little more insight on the same.
Thank you. Thank you for that question. But before I answer this question, I have a small correction to make.
Yes,
you
sir.
said Dr. Vineet Sehgal is very popular amongst pediatricians, and I would not agree to this. He would popular amongst chest physicians as well. So
Okay.
thank you, Dr. Sehgal, for being here. Yes. Okay. You spoke about how to begin this therapy. Okay. Now, most of these patients would come to you during their acute phase. So when they come to you during that acute phase and when they're really more symptomatic, you have a preference. Either you step up therapy or you give it combination therapy and step down over time. So if my patient has got milder symptom, if my patient has got associated bronchial asthma, most of the time being chest physician, I would get patients who's come to me mainly for bronchial asthma. And when I take the detailed history, I would probably, when I evaluate them, I realize that they have a component of allergic rhinitis as well. In this situation, probably a single monotherapy with intranasal corticosteroid will be enough in most of the situation. But if your patient has got more symptoms, if your patient is symptomatic from both ends, he's got, moderate to severe allergic rhinitis with this, I would prefer to start them on combination therapy. And I would start them with intranasal antihistaminic and intranasal, corticosteroids. I would continue this treatment for about a month or 6 weeks. That is 1.5 months. After that, once the rhinorrhea part settles down, I would prefer to remove the antihistaminic part and would continue them only on intranasal corticosteroid, continuing their asthma management. That's how I look at it. Thank you.
Right, sir. Thank you. Thank you for that clarification. Dr. Vineet,
Yes,
sir, what is your take on the use of combination therapy in the pediatric population having allergic rhinitis? I think because sometimes the guidelines differ when it comes to pediatric population as versus the adolescent and adults. So what is your take on this, sir?
Yeah, thank you, ma'am, for having me on the panel. It is slightly different. The issue, of course, is that allergic rhinitis in children is being recognized only very recently as far as the Indian scenario goes. As a distinct entity, we've been talking about allergic rhinitis just for the past 4 or 5 years. So that's why still our practice on allergic rhinitis is very limited. Our experience is very limited. And what complicates the matter is that most small children up to 6-7 years of age, the infective rhinitis or the viral rhinitis, viral URIs are kind of overlapping with allergic rhinitis. So to differentiate between the two sometimes is a challenge. But yes, once we have a child who has allergic rhinitis, because of limited studies in children less than 6 years of age, dual therapy or using an intranasal antihistamine is still restricted less than 6 years of age. But above 6 years of age, if a child comes to us, most of our children are quite sensitive to monotherapy with intranasal corticosteroids. So they respond pretty well to just using monotherapy, intranasal steroids. But of course, you have a small subset of children, especially with perennial symptoms and acute exacerbations in between, who benefit with the dual therapy. And of course, the dual therapy we use, the antihistamine we use is azilastine. Olapatadine was available some time back. I don't think it's very commonly available now and not much in favor. So azilastine is the way to go in combination with intranasal steroids, especially in children who have ocular symptoms also. So when you add the dual therapy, their ocular symptoms, eye symptoms also seem to respond pretty much better, and their need for intraocular steroids seems to go down. So we have a small subset in children in which we start with dual therapy, though most of them would respond very well to just intranasal steroids.
I agree with you, sir. Probably, yes, in the pediatric age group, we don't use less than 6 years. Probably in the subset of patients where moderate to severe persistent allergic rhinitis, or in combination with the lower airway involvement or the allergic rhinoconjunctivitis, we would be using this combination. we would be probably using it for a shorter duration. And as you rightly pointed out, we would switch it over to the intranasal corticosteroids once the symptoms are resolved. Mainly because in pediatric population, even though the nasal spray is quite easily used, sometimes the azilastine has a little bitter taste, and that may put off the children having the bitter aftertaste after using the nasal spray. Probably that may be one of the what I find in my practice. But otherwise, I think point well taken that it definitely has quite a role to be used in a subset of patients where their severity of symptoms are more. Dr. Agam Vora, sir, which patients are phenotypes? So now when we come right now in the evidence, in the era of evidence-based medicine, we are becoming more of personalization of medicine. We are thinking about phenotyping and endotyping of various diseases, and allergic rhinitis also is one among them, because as Dr. Vineet Sehgal was telling, we have been talking about allergic rhinitis more in the last few years. So which phenotype patients you think would benefit from the combination of therapies in the management of allergic rhinitis?
When we talk about different phenotypes with allergic rhinitis, you come across patients with allergic rhinitis with bronchial asthma. I see patients of allergic rhinitis with cutaneous allergy. I see patients of allergic rhinitis with rhinosinusitis with polyps, otitis media with effusion there. You may find allergic rhinitis having sleep apnea as a comorbidity. You may find allergic rhinitis in sleep apneics where they have adenotonsillar hypertrophy. So these are various phenotypes that I come across in practice routinely. And when it comes to combination therapy of choosing intranasal corticosteroids and antihistaminics, probably my preference would be for all these phenotypes. So when I flashed a couple of studies on it. So when you have allergic rhinitis with sinusitis, where you have allergic rhinitis with obstructive sleep apnea, where you have allergic rhinitis with adenotonsillar hypertrophy. So when you have this kind of phenotypes, I think this combination may have a preference, especially when patients have ocular symptoms. I think this particular combination works out well. Thank you.
Yes, sir. Definitely. Dr. Vineet, sir, what is the role of intranasal corticosteroids in the pediatric age group when you would start? And probably what is the molecule you would think you would be starting with for treatment of allergic rhinitis in the pediatric population?
Yeah, so that's a valid point. That what's the starting point for intranasal steroids? So usually the way it goes is that any child who comes to you with symptoms, it has to be more than mild symptoms. Most of these children with mild symptoms are anyway going to treat themselves at home with their old prescriptions or just make do with the oral antihistamines. So any child who has severe enough symptoms to land up in your clinic for consultation generally would mean that he already has a moderate severity of allergic rhinitis. And then there is no doubt that in this situation, intranasal steroids are the best first-line treatment, as Dr. Vora showed in his presentation, that all the pluses, it ticks all the boxes, be it congestion, be it sneezing, be it blockage, while the other modalities have selective effects. So especially in pediatrics, because you don't want to experiment too much, any child who presents to you with symptoms in the clinic of allergic rhinitis means generally that it's moderate severity, and you kind of start with intranasal steroids right away. Choice, of course, the furoids are the better choice, be it fluticasone, be it mometasone, for the simple reason that the affinity to the receptors with the furoids, it's better with the propionates. Yes, there are theoretical advantages of fluticasone furoid over mometasone furoid, but as we normally would like to kind of propagate or teach that both are equally effective. The point is to use the intranasal steroid and not just go on using antihistamines, oral antihistamines, right, left, and center. So use mometasone furoate, use fluticasone furoate. Either of the furates would work equally well. Of course, theoretical advantages would push you towards FF compared to MF. Then for practical considerations, either of the two.
Yes, sir. Probably because of the low systemic bioavailability of these molecules, and probably the little minor side effects what even those would bring. Yes, as you rightly pointed out, fluticasone and mometasone furoate are recommended for use about 2 years of age. When we are discussing, I would definitely request the audience to kindly send the relevant questions, which we can take it up with our expert speakers we have on the panel today. And also there would be a feedback link. I think I would request Anirudh to make it active for the participants so that they could interact more. Agam Vora, sir. Sir, the recent Association of Otolaryngological Society of India, that is AOI guidelines, I think they got, they released the Allergic Rhinitis guidelines recently, last year. So they have a component of mainly blockers and non-blockers in the management to make it more easily understandable for the people practicing. So how would you think this would change the patient management regimen?
Sorry, I think there was a gap in the you said blockers?
Yes, sir. So the Association of Otolaryngological Society of India, they recently released that.
They spoke about the blockers and
yes, sir. Yes, sir. They have a
component.
component on blockers and non-blockers in the management. How do you think it changes the patient management regimen?
It's an interesting concept, you know. I mean, to look at the disease from a different perspective and to
I think we
lost a video and audio both.
Sir, in the meanwhile, sir, Vineet, sir, I think let's just wait for 1 second if he comes back. Sir, in the meantime, very common concerns in the pediatric age group is it safe to use intranasal corticosteroids? Like we had issues like this in the past regarding the treatment of asthma. So how much safe do you think when especially it is used to safe to use intranasal corticosteroids less than 6 years old?
I think we are now at an advantage having used corticosteroids, inhaled corticosteroids for asthma for so many years now. So the acceptance for intranasal corticosteroids has been faster and much easier. I think the struggle was to start the ICS for asthma, but once we've got physicians around to that, or other pediatricians around to that, and the patients are convinced, now starting intranasal corticosteroids is a much easier kind of task. And of course, the misconceptions that we had to clear for asthma, they hold good for allergic rhinitis also. But then again, because we've been doing it over the years, it's been easier to explain to the parents that, you know, targeted dose at the target organ, it reaches faster and acts faster, and obviously a much lower dose is needed. And of course, the alternative available is the antihistamines, oral antihistamines, which have a huge component of drowsiness and impaired cognition. Plus, once you put the patients or the children on intranasal corticosteroids, the response is so quick that within 3 or 4 days, their suffering of the past few weeks or months goes away rapidly, and it's kind of an amazing response. And that kind of convinces the patients that what you are doing is pretty much the correct way to go. So it's not been too much of a challenge. I think it's more for us to convince ourselves that intranasal steroids is what the child needs, and you don't keep doing your promethazines and hydroxyzines and with due apologies, your fexofenadines and cetirizines, because if the child has severe enough symptoms, then don't beat around the bush with these syrups and go right ahead and start intranasal steroids. And if you may permit me about the blockers from the
Yes, sir, please, sir.
From the pediatric point of view, usually if the child comes with symptoms of blockage, I mean, commonly the children come to us with a running nose and sneezing as the common symptoms. But if they come to you with symptoms of blockage, then in pediatric patients, adenoid hypertrophy usually is the association which we commonly find. And luckily for us, if you start the child on intranasal corticosteroids, even the adenoid hypertrophy kind of shrinks over 2 to 3 months. So the symptoms of blockage go away with just the intranasal steroids. But yes, bigger children, adolescents who probably do not have adenoid hypertrophy and have blockage symptoms, there might be a case for using short-term decongestants, nasal decongestants for 2-3 days to kind of relieve the blockage. And of course, in the meantime, the intranasal steroids start taking their effect, and our blockers also do well in pediatrics, at least, just on simple monotherapy with intranasal corticosteroids.
Yes, I'm sorry, there was some net connection, and I would also agree to the same thing. With newer thing, probably most of these decongestants, etc., are losing their place in therapy. These antihistaminics, they work very well. Intranasal corticosteroids, also the molecule of interest that we're talking about, brings about its action in 8 hours time. And I don't think there may be a situation where there is so emergency to treat this congestion or this blockage. Most of these patients come with fairly decent ongoing symptoms, and the improvement occurs in less than 24 hours. So I think I have, in my practice, reduced the use of decongestants, chromones, any other molecule for that matter. I'm very happy using combinations of intranasal corticosteroids, antihistaminic, plus minus oral antihistaminic, plus minus leukotriene receptor antagonist, and my choice ends there. Thank you.
Yes, sir. Point well taken. I think definitely the intranasal corticosteroids do have a role in the management of various phenotypes. As you rightly pointed out, in children, especially with adenoid hypertrophy, where many of them are referred for unnecessary surgeries or so, probably usage of these trial of intranasal corticosteroids definitely reduces the size and probably the suffering of the patient, and probably alleviates the need for surgical management of such patients, as well as in obstructive sleep apnea. Point definitely well taken. Probably as we were having the discussion about decongestants, very popular in the treatment of upper respiratory conditions is oral as well as nasal decongestants. I think all of us brought out in the discussion that probably it has a limited role as we are moving towards more of intranasal corticosteroids. Sir, how much, I mean, when would you be using nasal decongestants, and for how long duration you would be prescribing? And why do we don't favor the oral decongestants or the nasal decongestants so much as compared to other molecules of treatment?
There may be issues in children, because children may not be able to sleep. They may be irritable, and when they are irritable, the parents are irritable, they don't let you also sleep, So in those situations, maybe there is some preference of using such therapies. When it comes to adult practice, I think I've almost given up using these therapies. To my mind, allergic rhinitis, or it's not your acute attack of asthma, the allergic rhinitis. So these patients are never, you don't have to be, though you have to be aggressive in therapy, you don't have to look at giving them symptomatic relief in 1 hour time or 2 hours time. This treatment brings about relief in less than 24 hours time, and I'm very happy using it. So I have by and large refrained from using this therapy for some time now. I would use decongestants in situations when there is associated asthma, associated underlying COPD patient is chest is congested and is not able to get about the secretions, I may use some mucolytics. Now, there is you need to have that balance. Suppose if you give them mucolytic, it brings about lysis of those disulfide blockage, and then probably mucus becomes thinner. With this liquefaction of mucus, if patient's cough reflex is not good, he may drown himself in his own secretions. So that may be a difficult scenario where there's a lot of liquefaction of sputum and he's not able to get it out. So unless your patient's cough reflex is good, unless he's got ability to bring out those secretions, I would not recommend use of mucolytics or decongestants, etc. So under supervision in selected situations, yes, you may use it, but my overall answer is big no.
Definitely. Sir, Vineet, sir, your take on this?
I would kind of, push the last part of the statement that sir made. It's very important, or probably more important in pediatrics, not using mucolytics, because children can't expectorate. And as sir very correctly said, you would actually make the child drown in his own secretion. So even the most fanciest of mucolytics, even the nebulized mucolytics, we never ever propagate in pediatrics, because you liquefy the secretion, but the child is unable to bring out the secretions. As far as the decongestants go, it's a matter of old habits dying hard. We still haven't given up the syrups that we learned in MBBS and MD. They are still reflexly there on your pen, and we still write them. I won't deny that probably pediatricians use them much more, because as I said, in the early years, at least the first 5-6 years, viral rhinitis or viral URIs are so common that reflexively we are writing it for those. And in that, our subset of undiagnosed allergic rhinitis children also get treated with that. But as we are becoming more aware about allergic rhinitis, I am sure we are able to tease out that no, this child is allergic rhinitis. He is not going to benefit with an oral antihistamine or decongestants. This is a viral rhinitis. There might be some role, but then again, decongestants have to be used with a lot of care, because unexpected deaths, arrhythmias, irritability, seizures, all have been reported, and it's best avoided, even in the viral URIs. Allergic rhinitis, almost no role.
Yes, sir. Point well taken. I think especially in pediatric population, we abuse this combination, especially oral decongestants, and it is usually definitely not recommended because of the associated side effects like headache, tremors, tachycardia, hypertension, among others. One point I would like to add on is the nasal decongestants, especially xylometazoline. Very commonly, people, at least patients tend to go to the pharmacist, and they tend to give this nasal decongestants. Even if we do come across, we should be telling the patients to be using it for a very brief duration, maybe about 5 to 7 days till the symptoms get better. And these do not help anything in the nasal itching, sneezing, or rhinorrhea in the management of allergic rhinitis. Prolonged use, definitely, as we know, it causes rebound congestion like rhinitis medicamentosa. So definitely we wouldn't be recommending. Definitely no below 6 months of age, because I have seen patients less than 6 months. Instead of saline nasal drops, they have ended up using the nasal xylometazoline. So I think we should be aware of this. So one more question, what comes up when we are in the concept of congestion, if we don't recommend decongestants, then what would is the management molecule preferred in these patients with severe congestion as being the presenting feature?
Severe congestion, of course, antihistaminic and intranasal corticosteroid, the combination remains the same.
Right, sir. So
it depends on the severity of presentation. So whenever you have moderate to severe presentation, I think my choice would be intranasal corticosteroid with antihistaminic to begin with. And as I said, over time, when patients improve, you remove antihistaminic from it and continue only intranasal corticosteroids. So my preference is for monotherapy. But when patient needs it, you can always start with combination therapy, and over time you can reduce it to monotherapy.
You can step it down. Correct, sir. Vineet, so one question was from one of the audience was, what problems can AR cause in children, pediatric populations, which pediatricians may miss out when the patients are being seen by the pediatricians?
Sorry, I missed the first part. What problems?
What all other comorbid factors or what other issues can allergic rhinitis cause in children, which can be generally missed out during examination from pediatricians?
Yes, so allergic rhinitis in children has a huge comorbidity profile. Of course, the commonest comorbidity with allergic rhinitis is asthma. In children also, we believe that almost 3/4 of all patients with asthma have allergic rhinitis. So if you have a child with asthma, you must evaluate for allergic rhinitis also. Because the concept of unified airway disease, if you do not control the allergic rhinitis, your control of asthma is also going to be poor. Undiagnosed allergic rhinitis or poorly treated allergic rhinitis has a lot of effect on cognition. Children don't sleep well, they don't get up fresh, they do not concentrate, they do not eat well. So their cognitive side effects of allergic rhinitis leads to poor school performance, poor sleep, irritability. That's one part. Then allergic rhinitis coexisting with adenoid hypertrophy and obstructive sleep apnea. That's another part. Allergic rhinitis giving rise to chronic middle ear effusion leading to hearing loss. That's again another thing you would not want to miss. So as we like to kind of teach, allergic rhinitis is not a simple sneeze. You know, do not just think of it as a sneezing problem ki thoda sa dawai diya theek ho jayega. There is a huge comorbidity associated with allergic rhinitis and huge cost as far as treatment and loss of productivity goes. So allergic rhinitis with adenoid hypertrophy, obstructive sleep apnea, middle ear effusion, effect on sleep and cognition, poor school performance, and of course asthma.
Yes. Yes, sir. So it is not a simple upper airway disease. I think it has a lot of implications if left untreated. Sir, we have been talking about intranasal corticosteroids being the drug of choice in the management of allergic rhinitis. I think we have given that message. But again, another aspect of treatment of allergic rhinitis is antihistamines. So we see a lot of controversy, especially on the combination of antihistamines versus two molecules being used together. So when should we be using antihistamines, and when would be the combination preferred to both of you, sir?
Combination of antihistamine with intranasal corticosteroid, right?
Yes, sir. That is the first question. And then combination of antihistamines and leukotriene receptor antagonists.
Okay, my take on it. If I have a patient of bronchial asthma with allergic rhinitis and is symptomatic from allergic rhinitis point of view as well, when my asthma is not under control with the combination inhaler that I've given him, so my patient is on beta agonist with a steroid combination inhaler. He is on intranasal corticosteroid inhaler, and still he needs more inflammation control. My choice would be on combination therapy with leukotriene receptor antagonist with antihistaminic oral, because in that case it can take care of all allergies at multiple levels. If my patient does not have much of systemic components, if my patient does not have much of asthma component, and he's got predominant this component, my choice of therapy initiation will be intranasal corticosteroid with antihistaminic. But as was discussed in previous questions, and as Vineet bhai said, it would be wiser to do lung function test for every patient who present with allergic rhinitis, because they may not be aware of their asthma, and you can identify asthma only by doing spirometry. In that situation, if patient has a reversible airway disease, it is wiser to put them on inhaled steroid as well. So intranasal sprays and inhaled corticosteroid with beta agonist would be the combination therapy at that stage. So leukotriene receptor with antihistaminic, when patient has both systems involved and you need additional anti-inflammatory, my choice would be on that combination. Thank you.
Thank you, sir. Vineet, sir.
I pretty much agree with what Dr. Agam said, only with the caveat that somehow I think Montelukast is a hugely overrated molecule. I think it's better to put Montelukast into the municipal corporation water supply and make sure everybody gets it and escapes all allergic diseases. There is a definite subset which unfortunately we can't identify that phenotype who responds beautifully well to Montelukast. But identifying that by our clinical judgment is difficult. And in pediatrics, we've often seen there is a small subset children, you put just leukotriene receptor antagonist as a monotherapy, they do very well, but that unfortunately is a very small subset and very difficult to identify with our clinical judgment or clinical parameters. But yes, as sir mentioned, allergic rhinitis and asthma, and you are not getting control just on your inhaled steroids or intranasal corticosteroids, then, and there is a dual disease going on, both the upper airway and the lower airway, then there probably is a place for at least trial of the LTRA plus antihistamine, because you can't keep on hiking up the corticosteroids, because remember, corticosteroids red line very quickly. It's not a linear sort of effect. Beyond a certain dose, you with incremental doses, you don't get better anti-inflammatory action. So beyond 400 micrograms in children and probably above 800 micrograms in adult, increasing the dose of inhaled steroids in asthma especially doesn't give us too much benefit. So before stepping up to biologics and other fancy stuff, trying a LTRA plus an antihistamine if there is a nasal component might be a wise thing to do. But in pediatrics, of course, we limit just to plain LTRA and don't use oral antihistamines too much.
Right, sir.
That I want to add something to it. I agree to Vineet. A lot of people believe that Montelukast is overrated. I remember launching Montelukast in India in 2003, 2004. I was involved in the initial studies in the launch of Montelukast. I was very much excited when I looked at the molecule and the available data that time. And to my mind, I had Montelukast as the option for all those children who do not want to take inhalers. For a variety of reasons, the children and the parents, some are reluctant to use inhalers, and I thought this would be good drug of choice there. Of course, I was proved wrong in no time. But it took us almost 7 or 8 years before we realized that Montelukast is a good drug provided used in the right indication as add-on therapy. Montelukast may be a drug of choice when you're looking at vagus mediated asthma. See, any psychological, any stressor which is exacerbating asthma. It could be a very good drug for exercise-induced asthma, monotherapy given beforehand. Suppose your child is going to participate into marathon tomorrow and you give the Montelukast today, it definitely brings about improvement in exercise-induced asthma. But unluckily, we don't have much exercise-induced asthma in our country. We have exercise worsening your asthma. You may get awareness about your asthma during exercises, but that's not actual exercise-induced asthma. But if you have so, probably Montelukast is a drug of choice. I remember writing a review article in 2013-14 about a decade of experience with Montelukast. And I was viewing at all this, and there also I came across a lot of people who did not believe in Montelukast at all. They believe that it is as good as water, just a placebo, which is of no use. And then there is one more group where I'm included. We feel that yes, it's a good drug provided you choose the right patient. Initially, we felt that leukotriene levels monitoring could be of use, and there was Hinduja Hospital was doing urinary leukotriene levels. I did ask for in few of the patients, but really didn't find it correlating it well. But yes, Montelukast, since it is safe, monotherapy, once-a-day therapy, no drug-to-drug interaction, is a good choice as an add-on therapy when your patients are not getting good control. Before, as Vineet said, before thinking about stepping up your steroid, before thinking about biologics as the option for allergy, I think I would consider it. Thanks.
Definitely, sir. Point well taken. I think as monotherapy, it would be better. Even though we see a lot of prescriptions with combination with various antihistamines because it can be taken together. I think, especially in the pediatric population, we do endorse monotherapy. And again, with the maybe with a black box warning by the FDA, which has been recently highlighted regarding the probable neuropsychiatric manifestations of the long-term side effects of Montelukast, even though even prolonged use we may not have seen much, but probably sticking to monotherapy as guidelines recommend may be the way forward. Sir, another question from the audience was, for how long can we safely give intranasal corticosteroids in adults and pediatric age group? And should they be tapered and stopped like oral corticosteroids? If yes, how?
That's a very interesting question. I would restrict my talk to adult and I would leave both of you to answer the pediatric age question. My answer is very simple. You would continue it as long as your patients require it. And your patients would require it for a longer time. If you're talking about allergic rhinitis, if you're talking about IgE-mediated allergic rhinitis, your patients are going to live with it. You're not going to be cured of it. It's not like your infection. It's not like tuberculosis where 6 months of AKT is going to cure you of tuberculosis. It's not like your COVID where 5 days, 7 days, 15 days treatment would cure you of your disease. You're going to live with allergic rhinitis and there would be ups and downs. There would be fallen. Your patient may go into good remission, but they would continue to have this allergic exacerbation depending on the exacerbator they have. It may be a hormonal exacerbator, it may be a psychological, it may be environmental, it may be occupation related or whatever. And hence your patients would require it for a longer time. You may be able to give them drug-free period or a drug holiday period, but this treatment needs to be continued on a longer basis. I have patients where these patients are taking this treatment for probably more than 10 years, depending on that allergy presentation. And on the other hand, I have patients who have done extremely well and disease has gone into good remission and they've stopped the treatment. So it would depend on the phenotype, it would depend on the presentation, and it would depend on the environment in which he lives. See, you will come across patients who can't change their house. You will come across patients who've got these gardens and farms next to them, and it's not possible for them to not have allergic rhinitis. So in those situations, yes, they would need it for a longer time. Thank you.
Vineet, sir?
Yeah, so patients do not follow guidelines and patients do not follow their doctor's instructions. Your most faithful and most regular of patients do not follow your prescription to a T. And luckily or unluckily, whatever you might call it, there is an excellent feedback loop as far as allergic rhinitis goes. When the patient starts feeling better, he will stop the intranasal steroid, however much you might have told him कि आपको perennial allergic rhinitis है, you are going to need it forever and ever. But when the patient feels better, he stops. When he starts having symptoms again, he starts using the intranasal steroid again, which is okay, which is actually not wrong. As far as how long, as sir said, if it's a perennial allergic rhinitis, the patient might require it for years on end. But if we can identify a particular allergen, if that is the one allergen is the cause, and you can then encourage or induce the patient to go in for immunotherapy. So a person who's needing prolonged intranasal steroids is the one who probably should get an allergy test done. And if you can identify an allergen which is amenable to immunotherapy, he should go in for immunotherapy. The other question was that should it be tapered? No, unlike asthma, the steroids do not need to be tapered for allergic rhinitis. Then there was another question, pediatric recommended duration, similarly same. So there is no recommended duration. It all depends on your control of symptoms. For a seasonal allergic rhinitis, of course, 1 or 2 months or maybe 3 months of the the intranasal corticosteroids would be enough till the next season comes around. Then you probably start all over again. For for the perennial allergic rhinitis, like I said, it depends on the feedback loop of the patient. If he doesn't feel better, he can continue for as long as needed, but then consider immunotherapy. If he feels better, he can stop after 1 month, 2 months, 3 months, depending on the response, and then start all over again if needed.
Right. Sir, when we are on intranasal corticosteroids, the other question was from one of the audience was, can the use of intranasal steroids, mainly fluticasone furoate, can be used if the patient is on antituberculous treatment for pulmonary tuberculosis?
Oh, yes.
Absolutely, absolutely.
Yes, sir.
No worries. No worries.
Very well. If your patient has allergic rhinitis and if he needs treatment, it can be very well treated with intranasal corticosteroid. Trust me, steroids can be very well used, whether local, systemic, injectable, if patient is on proper treatment for his associated disease. In the sense, steroid will not make disease resistant. Your drug sensitive bacilli will not become drug resistant if you give steroids. You have to treat all comorbidities accordingly with treatment required as per the treatment guidelines for that disease. And you need to treat tuberculosis with drug sensitive, whatever drug sensitive works, you have to choose regimes accordingly. So if you need allergic rhinitis treatment with steroids, please go ahead and treat. Thank you.
Correct, sir. Point well taken. I think there shouldn't be a hindrance for treating patients with tuberculosis. So the other question was, does the steroid cause stunted growth in the long run, apart from fungal infections in the nasal area?
No, especially the intranasal corticosteroids. Anyway, it's a much lower dose compared to the inhaled steroids for asthma. And as far as inhaled steroids for asthma also goes, doses up to 800 micrograms per day in a bigger child hardly cause any loss of height, maybe about a centimeter, which also they can make up once you stop the inhaled corticosteroids. However, like I probably mentioned earlier, most of our asthma would be controlled at 400 micrograms, maximum of 400 micrograms a day of either fluticasone or budesonide, and that has no long-term effect on growth. And as the classic statement goes, it is asthma which can cause the loss of height or stunting rather than uncontrolled asthma, rather than the steroid. So control the asthma and control the allergic rhinitis. Don't worry about the height. It'll come along fine.
Correct, sir. Point well taken. Sir, when we are on the treatment of allergic rhinitis, probably the other aspects of treatment of allergic rhinitis, what we haven't touched upon is when do we think about using biologicals or immunotherapy? It's a little controversial, especially because immunotherapy, some specialties do endorse it and some specialties may not. What is your take, sir? Both of you.
Yes, so I don't have much experience of immunotherapy. Maybe I never come across situations where I had to probably get it done. But yes, I have used biologics extensively, especially omalizumab. We've started using somewhere around 2006, 2007, and we've got almost 15 years of experience of omalizumab, and now with biosimilars coming of omalizumab therapy, cost therapy coming down, I think more and more patients can take advantage of it. It is very simple logic to understand that you have an IgE mediated reaction. Those IgEs bind to mast cells. If you have antibodies which bind to this free moving IgEs and does not allow it to bind to mast cells, the mast cell does not degranulate, the inflammation does not happen. Though in practice it doesn't happen so smooth, but yes, the IgE anti-IgE complexes would prevent mediators of allergy to be released. I have used it in allergic rhinitis with bronchial asthma. So your indication will be uncontrolled bronchial asthma who are on very high intensity treatment. Your step 4, step 5 GINA, if you're aware of this treatment guidelines. These patients who are on high dose inhaled corticosteroid with a beta agonist, with a add-on leukotriene receptor antagonist, and or they may require oral steroid for maintaining their symptoms or preventing exacerbation. You would consider them for biologic. Luckily, we have 2 more biologics available now. So you have one mepolizumab available, you have one interleukin-5 receptor antagonist, that is the benalizumab available now. And it would be very interesting when the next 1 year when we realize how to choose the biologic. But trust me, if you choose the right drug for a right patient, it really does wonders. And I can at least, when I'm talking to you about this, I can think about at least those 5 or 6 patients where the oral steroid requirement completely went away. Their exacerbations completely went away. These patients are very well managed on the combination inhaler, which otherwise would not give them symptomatic relief. So yes, there is a definite place for these biologics. Only thing is, there should not be a reflex action of prescribing biologic to anybody who's not responding to your line of treatment. You will have to understand the difference between uncontrolled asthma and severe asthma. The current guidelines say that severe asthma is a retrospective diagnosis. So when a patient comes to you, you look at all this, his treatment compliances, you confirm diagnosis, look at associated thing. As if you're a bronchial asthma patient, your allergic rhinitis you've missed, a GRD you've missed, a pet in the house you've missed, a psychiatric stressor you've missed, etc. When you identify those things, when you address those things, and still patient remains symptomatic and requires high intensity treatment, only those are the patient to be labeled as severe asthma. Out of severe asthma, you have to look at the phenotypes. So only allergic IgE mediated severe asthmatics would be candidate for omalizumab, and eosinophilic mediated otherwise uncontrolled asthma would be candidate for other biologics. But when you have neutrophilic predominant asthma, when you have obesity related asthma, when you have elderly lady having asthma, so those are the different phenotypes, and their biologics may not work well. Thank you.
Thank you, sir. Vineet, sir, what is your experience or take on?
As far as omalizumab goes, of course, in pediatrics, we have limited experience because the age group for omalizumab has dropped only recently, the recommended age. We've used it in a few patients with asthma, but to my knowledge, at least in Delhi, probably we haven't used it for allergic rhinitis as of now. On the other hand, yes, our resistant cases of uncontrolled cases of allergic rhinitis, especially the perennial variety in which aeroallergen sensitivity is probably a prime culprit, who are uncontrolled, we do put them through allergy testing. And if we can identify one or two allergens, which are the extracts of which are available to us, we can consider immunotherapy, and our allergists have tried and they give fairly good results. Subcutaneous immunotherapy, of course, is licensed and sanctioned for use. Sublingual immunotherapy is used off-label by some people, but I wouldn't, put my neck out and suggest that you go ahead with sublingual. But yes, subcutaneous immunotherapy, if there is an aeroallergen or an allergen which you can identify for which you have extracts, you can try and desensitize if the patient is not controlled on good pharmacological or pharmacotherapy. Omalizumab in allergic rhinitis, no experience. In asthma, yes, limited role. As sir mentioned, it should be a IgE-mediated asthma. The eosinophil count and the other requirements should fit in whatever is needed.
Definitely, sir. I agree with you that especially in comorbid asthma or sometimes with chronic rhinosinusitis with nasal polyposis, some of the ENT colleagues have used omalizumab. So that may give a little more benefit. Immunotherapy as being a practicing allergy specialist. Is licensed by the Drug Control General of India as of now, and definitely pediatric and adult population do well, especially in selected population where we have to identify the probable allergen and select the patients properly. So that gives us good results. So I think we have come to the end of our session. I think we are overboard by a couple of minutes. I think, sir, just to summarize, I think both of you have brought out the idea that allergic rhinitis is not just a disease of the upper airway. We have a lot of comorbid conditions associated with allergic rhinitis, and intranasal corticosteroids remain the drug of choice in the management of intranasal corticosteroids, even though the combination of intranasal corticosteroids or with the intranasal antihistamines can be used in patients with moderate to severe persistent allergic rhinitis. for a briefer duration and then stepping down to intranasal corticosteroids as the patients get better, with the various aspects that we have limited role of use of decongestants, mucolytics in the treatment of allergic rhinitis, and probable good patient selection for comorbid factors for the use of biologicals and immunotherapy gives us an overall bird's eye view of the management of recent innovations of allergic rhinitis. I would definitely thank our speaker Agam, Vora sir and Vineet, Sehgal sir for joining us on this panel discussion, and Sanofi for giving us a platform for discussing various management aspects of allergic rhinitis. Request the participants for giving us the feedback on the feedback form, and thank you for all for joining us even on a working day, as sir was rightly pointing out in the beginning. It's a weekday evening where probably many of the practitioners have a busy OPD practice. In spite of that, taking time out to join us for this important session. So thank you, sir.
I also want to make a comment.
Yes, sir, please.
Trust me, the success of a program is in its moderation. So I must tell you, you wonderfully moderated this program, and I was really anxious, when the program was brought to me. I said, how would I manage? But the minute they told me that, yes, you are going to be moderating and Vineet is going to be there with you to probably, look after or help me with a difficult situation, I couldn't resist the opportunity. So thanks for being there. Thanks, team there. Ketan, you did a fantastic job. And of course, Anirudh, absolutely flawless, your platform. I thoroughly enjoyed being on this platform. Thanks, everybody.
Thank you. Thank you so much.
Bye-bye.
Dr. Ketan, can we wrap up the session?
Yes, ma'am. I think you really well summarized the entire session, and thank you, Dr. Agam and Dr. Sehgal, for being with us. With this, we can close the session. Thank you to the support staff. Thanks, Priya. Thank you, everyone. Good night.
Thank you. Good night.